Hi guys, I'm back again with another video in our study series. Thank you for coming back to study with me again today. Today we're speaking about fluid and electrolyte balance, and let's get started right away. An electrolyte is a mineral and it's responsible for some important functions in our body. Now, there are three hormones related to fluid balance in our body that I want to speak about right now. The first one is antidiuretic hormone, ADH, and that hormone tells our kidneys to reabsorb water. So what's going to happen, where the kidney is going to hold on to water and it's going to hold on to sodium. Remember, with antidiuretic hormone, if you have too little antidiuretic hormone, you're going to end up with diabetes insipidus, and that has nothing to do with your blood sugar, right? Next hormone, aldosterone. Aldosterone, the kidney is going to hold on to sodium, it's going to hold on to water, but it's going to get rid of potassium. And parathyroid hormone helps to absorb calcium in the body. So I have a question for you. Who is most at risk for fluid and electrolyte imbalance? Is it the older adult? Is it the infant? Is it neither one of them? Is it both of them? Is it the elderly alone? Is it the infant alone? What do you think? You're right, you got it right. It's both of them. The baby is primarily water, right? And the older adult is usually dehydrated. They're usually dehydrated. They're partly dehydrated. So these two categories of clients, the infants and the older adult, are most at risk for fluid and electrolyte imbalances. So here we have dehydration and fluid overload. And what I needed to pay attention to are the signs and symptoms and the nursing care of each. All right. We have an electrolyte relationship chart here. You can just review it at your leisure. I'm not going to go over it right now. But we're going to start with our first electrolyte, which is potassium. And the normal value is 3.5 to 5.0. And I don't want you to get too hooked up on the values. The reason is the values vary from textbook to textbook, from instructor to instructor. But what I'm going to say to you, when you're taking a standardized exam, the value is going to be clearly out of the range. So if, for example, it's hyperkalemia, they're going to give you a value of like 6 or 7. They're not going to give you a value of 5.1. Okay, same thing. If they were to give you hypokalemia, they're not going to give you 3.4. They're going to give you 3, 2.5, 2. It's going to be clearly out of the norm. Okay, so I know sometimes I have students that contact me, oh, what value should I be using? Use the value that you learned in nursing school. Because, like I said, on a standardized test, it's going to be clearly out of the norm. Okay, these are the values that I'm using for this video today, 3.5 to 5.0. Potassium is responsible for some neuromuscular activity in the body. It maintains ICF, intracellular fluid balance. It's part of acid-base balance. And I want you to know, potassium should not be given IV push or IV bolus, because that can actually kill the client. So no IV push, no IV bolus for potassium. Now, we're going to speak about hyperkalemia, which is potassium over 5.0. Increased changes except heart rate and urinary output. Now, what do I mean by that? What do I mean? The changes that you're going to see are going to be increased, but heart rate and urinary output are going to be decreased. And it's going to look like this. You're going to have tall T waves. You're going to have diarrhea, increased deep tendon reflexes, but the heart rate is going to be decreased. Bradycardia and the urinary output is going to be decreased. So everything is going to be increased except heart rate and urinary output. How do we treat hyperkalemia? Well, what I want you to do is monitor your client's cardiac status, meaning your client is going to be on a cardiac monitor, right? And I also want you to be kind to your client, right? And that is because we're going to treat them with kind. Electrolyte, which is the brand, the generic is in parentheses, sodium polystyrene sulfonate. We're going to give insulin, and remember, regular insulin is the only insulin that can be given IV, sodium bicarb, diuretics, and your client may also, if it's really bad, need dialysis. Okay? So remember, for your clients with hyperkalemia, be kind to them. All right? Okay, so now we're speaking about hypokalemia. So you're going to have decreased changes except heart rate and urinary output. So everything is going to be decreased except the heart rate and the urinary output. So as you can see, flat T waves, constipation, decreased deep tendon reflexes, hypotension, but the heart rate is increased, so you have tachycardia, and the urine output is also increased. So how do we treat hypokalemia? Well, we're going to administer potassium. We can give it orally. When we give potassium orally, we give it with food. We can give it intravenously, but it's going to be diluted in fluid, and we're going to administer it slowly. And we can also teach the client to increase potassium in their diet with foods that are high in potassium, such as the foods that are on the screen. Sodium, the normal value is 135 to 145. It's in all body fluids. Sodium is present in all body fluids. And what are some of the functions? Fluid balance, acid-base balance, and nerve conduction. So when you hear hypernatremia, right, I want you to think dehydration. There is a D in sodium, there is a D in dehydration. So hypernatremia, think dehydration. So what would your client present like? Dry and sticky mucous membrane, a rough dry tongue, they're going to be thirsty, and they're going to have vital sign changes, right? So they're going to have a decreased blood pressure but an increased heart rate. Okay, so how are we going to treat our client that have hypernatremia? We're going to monitor their sodium intake and decrease it, right? Your client is going to avoid certain medications, but that's going to be in consultation with the medical provider, with the healthcare provider, right? We're going to administer IV fluids, and we're going to monitor intake and output of our client. We're going to ensure adequate water intake, especially with older adults. Remember, older adults get into fluid and electrolyte imbalances more easily than others. With hyponatremia, there is an O in sodium and there is an O in overload. So with hyponatremia, I want you to think fluid overload, right? So your client is going to be confused. They're going to have personality changes, and they may possibly have seizures, okay? So how are we going to treat hyponatremia? Well, we have too much fluid, so we're going to restrict fluid. Your client is probably going to be, or most likely going to be, NPO. We're going to administer diuretics, daily weights, right? Because your client has too much fluid. Our next electrolyte is calcium, and calcium, normal value from 9 to 11. One of the things that I see is that sometimes students, to remember this, students will say, for calcium, call 911, right? And that's like a memory tip. And calcium assists in building bones, teeth formation. It facilitates blood clotting and is essential for nerve impulses. Skeletal muscle contraction, normal heart and muscle contraction, because remember, your heart is a muscle. All right. So hypercalcemia, I want you to think bone, stones, groans, psychiatric overtones. Bones, stones, groans, psychiatric overtones. And those are going to be your signs and symptoms of hypercalcemia. Bone pain, abdominal pain. Your client is going to have kidney stones, and they're going to have confusion, altered mental status. Bone, stones, groans, psychiatric overtones. How do we treat hypercalcemia? We're going to give the client a medication called calcitonin, right? Calcitonin. And if it's really severe, we're going to do dialysis, right? Calcitonin and dialysis. Hypocalcemia, I want you to remember tetany, twitches, trousseaus. Tetany, twitches, trousseaus, right? And remember, trousseau sign is when we inflate the blood pressure cuff and the arm and we get the spasm in the hand. So trousseau sign is a late sign of hypocalcemia. Another sign that we have is Chavastic sign, right? Chavastic sign, that's the sign where you tap on the facial nerve and you get the spasm in the face. But Chavastic sign is not as reliable as trousseau sign. So that's why I have a whole thing there for trousseaus. But just remember, hypocalcemia, tetany, twitches, trousseaus. Now, how are we going to treat hypocalcemia? We're going to tell our client to take calcium supplements before meals, and they can increase their consumption of dairy products. Okay? Next electrolyte is magnesium, 1.5 to 2.5. It's responsible for muscle relaxation. It's involved in bone formation and some biochemical reactions in the body. Now, with magnesium, what I want you to know, the symptoms will be the opposite of the prefix, okay? So right now, the prefix is hyper, which is increase. So the symptoms will be the opposite, which is decrease, right? So with hypermag, the symptoms are going to be opposite of the prefix. Okay? And if you have too much magnesium, how are we going to treat you? Well, we have another acronym, HEM. We're going to hemodialysis, or we can give the antidote, which is calcium gluconate. And we're going to have to monitor labs and deep tendon reflexes in the client. With hypomag, the symptoms will appear opposite of the prefix. So with hypo, it's going to be the opposite. So everything is going to be increased, right? So instead of muscle relaxation, we will have muscle excitation, and everything will be increased, right? So for the treatment, we're going to give magnesium by the IV, via IV, intravenously, or the person can increase their oral intake of magnesium. We also have magnesium that comes in pill form, in tablet form, okay? Phosphorus is the next electrolyte that we're going to look at. And when it comes to phosphorus, the normal phosphorus is 2.4 to 4.5. And it's involved in muscle contraction, right? So with hypophosphatemia, Here we go. Tetany, trousseau's, twitches, Chavaskit sign. What does that remind you of? Is that something we've seen before? Is that something we did before? That looks similar to hypocalcemia, right? So remember, the relationship between calcium and phosphorus is inverse. They're the opposite of each other. So when there is high phosphorus, there is low calcium. So the signs and symptoms appear almost similar to hypocalcemia, right? So what are we gonna do for hyperphosphatemia? We're gonna use phosphate binding medications. And you see this a lot in dialysis patients. So you gotta avoid food high in phosphorus. You have to manage signs of hypocalcemia. You have to teach the client about phosphate containing substances. And your client, sometimes to get the phosphorus down, they will need dialysis. With hypophosphatemia, the muscles are gonna be relaxed, right? You're gonna have weakness. And remember, your diaphragm is your muscle of breathing. So if the muscles are too relaxed, you may actually get respiratory failure. Okay, so to treat it, we can give oral or IV phosphate replacement, and we're going to encourage and teach the client about foods high in phosphorus. Chloride. The normal value is 95 to 105, and it's essential to acid-base balance. It's involved with cellular metabolism, it works with sodium, and it binds with hydrogen to form hydrochloric acid, which is our stomach acid. Hypochloremia. You do not see alterations in chloride unless there is something else happening in the body. It really does not occur by itself. So to correct it, you really need to correct the other imbalances that are occurring. So some of the things that we do give are, we give IV solution, we give lactated ringers, we can give sodium bicarb, diuretics, and we try to restrict or avoid sodium and chloride intake. Hypochloremia, again, doesn't really occur by itself. It occurs like while other things are happening in the body, like there are other electrolyte imbalances going on. So the treatment is really to correct the imbalance. We can replace chloride with IV normal saline. We should also avoid free water, and we can have the client take high chloride foods. What foods are high in chloride? Do you know? So remember, C for chloride, C for cabbage family. The cabbage family is high in chloride. And last but not least, lithium. Did you know lithium is an electrolyte? Yes, lithium is an electrolyte. So let me just give you a little fun history about lithium. 7-Up soda, right? The soda 7-Up, the up ingredient was lithium a long time ago, right? Way back, a long time ago, the up ingredient in 7-Up was lithium. And the number 7 is the atomic mass of lithium. That's the atomic mass of lithium. So that's just a little history on lithium. But lithium is an electrolyte, and you can have lithium toxicity. Now, when lithium toxicity is acute, you get GI symptoms, nausea, vomiting, diarrhea, anorexia, stuff like that. But when it's chronic, you get neurological symptoms like ataxia, slurred speech, lethargic, like the person look like they're like somewhat like out of it with the neurologic symptoms. Now, lithium is used to treat bipolar disorder. So if you have too little lithium, you're gonna get signs of the bipolar disorder. You're gonna have emotional changes. So that's the notes that I have for you. on fluid and electrolyte balance. I really hope you learned something from this study session. I want to thank you for coming out to study with me again today. Please like the video, hit the notification bell, and subscribe to the channel so you never miss another video from me. Again, thank you for studying with me. If there is a topic that you would like me to cover, leave a comment below in the video. And again, thank you, thank you, thank you. Bye-bye.